All right. Good afternoon, everyone, and thank you for joining us today for our monthly webinar presented by our program director, Altsai, and Mimi Amalang, the Stroke Program Evaluation Specialist. This is Nikki Anderson, the Stroke System Nurse Specialist for the Minnesota Department of Health Stroke Program. Before I hand things over to them, I'd like to go over our typical housekeeping items and then a few program updates. As usual, your lines have been muted upon entry to the webinar. Please ask questions by typing them directly into the chat throughout the presentation, and please remember to select everyone. We will keep track of these questions and we'll address them at the end of the presentation with our open Q&A. And today I'm going to share a few MDH updates and then hand things over to Mimi, which she'll present some information and data that we compiled that describes some of the impact that our program has made over the past 6 years. And finally, our program director, Al, will provide an overview of our program activities planned for the next 3 years. Regarding statewide educational opportunities, the 2021 Minnesota Statewide Stroke Conference, typically hosted in November by the Minnesota Stroke Association, has been canceled due to concerns about COVID-19. Keep an eye out for other education and networking opportunities or contact MSA. But as you can see here, they are continuing to have a webinar at noon on the same day, and the registration link is included here and will be in our follow-up email as well. And due to the ongoing challenges of in-person education, you may wish to check out our MDH Learning Center, which hosts free online training opportunities that include contact hours. Information about how to access the MDH Learning Center, as well as any other educational opportunities that become available, are posted on the education page of the MDH Stroke Program website. And a final MDH update is to please continue to notify our team here of any contact changes within your stroke programs. So with that, let's get started. Since 2007, the Minnesota Department of Health has been funded by CDC to implement the Paul Coverdell National Acute Stroke Program. In the last funding cycle, over the last 6 years, our scope of work included pre-hospital stroke care, emergency treatment, inpatient care, and post-discharge follow-up. We continued to implement the stroke registry and expanded and strengthened the statewide stroke system of care. The project period for our last funding cycle ended in June. To wrap up this grant, CDC asked all grantee states to showcase the impact that we made since 2015. Mimi is going to talk about how we've done that.
Thanks, Nikki. Hi, everybody. My name is Mimi Amalang. I am the, as Nikki said, evaluation specialist or program evaluator for the stroke program. And that means my role is to make sure that we're fulfilling our evaluation and reporting requirements up to CDC, which is our funder, as well as more broadly evaluate and monitor our activities so that we know that we're moving towards our goals as a program, we're meeting the needs of the stroke system of care in Minnesota, and we're really making an impact. So as our last grant cycle wrapped up this summer, we worked on several final evaluation products that were intended to summarize where we are now as a program and the progress that we've made over this last 6-year cycle. So the first of those, as Nikki mentioned, were 2 health impact statements that briefly described our work on 2 program outcomes as selected by CDC. And then another was our annual performance measure reporting, many of which were drawn from the hospital inventory survey, which we asked you all to complete for us this August. So I'm going to share a little bit of what we included in those health impact statements, as well as some highlights from that hospital inventory survey, which were a big part of our performance measures and will also be informing our work going forward. So our first health impact statement described progress on the outcome of increasing statewide reach of acute stroke patients. For this, we really focus on the growth of our hospital designation program, which I'm sure many of you are already quite familiar with. But as a recap, MDH began designating hospitals in 2014, and we've continuously evolved our approach to align with changing guidelines for stroke care and to improve the insights we gain from the process, as well as the experience for our hospital stroke teams. Over the years, we've monitored the impact of our designation program by tracking the number and location of designated hospitals across the state. We then also calculate the percentage of the Minnesota population that lives within a 30 and then 60-minute drive of a designated hospital. So as you can see from these maps, in 2012, many parts of the state did not have a designated hospital, and many Minnesotans did not live within that 30 or even 60-minute drive from a designated hospital. This was particularly true outside of our major metropolitan areas. As you can see, those shaded areas on the map, which represent those 30 and 60-minute drive times, were really concentrated around the major cities in our state. So there's a stark contrast with our 2020 map, which shows designated hospitals really spread throughout the state so that most areas are within a 30 to 60-minute drive. And in fact, 89% of Minnesotans now live within a 30-minute drive of a designated hospital. So we feel that the increased number and accessibility of designated hospitals is a success in its own right, but we wanted to dig a little bit deeper and see whether we could draw any conclusions about the impact of designation on quality of care and stroke outcomes. These are both very complex issues, and we're not able to definitively conclude that designation alone has driven changes or improvements in quality of care or outcomes. You guys probably know better than I do that there's a lot of factors that go into both of these. So with that caveat in mind, we do have some data that suggests that growth in designation may have led to some improvements in stroke quality of care, especially in those rural areas. So we saw from 2012 to 2017 that treatment of stroke patients with IV alteplase increased significantly among all of our rural hospitals. And that was particularly dramatic in those acute stroke-ready hospitals that were newly designated between 2014 and 2015. And again, we began designating hospitals in 2014. So stroke mortality, again, quite complex, but we do see some trends that suggest improvements over the same time period where we were really ramping up that designation program. And again, we see this particularly in areas outside of metropolitan counties that were already fairly well covered as far as access to designated hospitals go. So from 2011 to 2019, those metropolitan counties saw pretty flat stroke mortality, whereas our rural, our micropolitan, and our small metropolitan counties all saw decreases. So I want to stress again, we're not directly attributing these changes to designation, and especially not only to designation, but we still think it's worth highlighting these trends. So I'll turn now to our second health impact statement. This one looked at improved quality of acute and subacute ED and hospital stroke care. And for this one, we really focus on the Minnesota Stroke Registry, which again, I'm sure many of you are familiar with. But just to summarize, prior to our registry, there was no systematic collection of data on stroke quality of care or outcomes in Minnesota. And because you can't improve what you don't measure, there were also no statewide efforts to improve stroke quality of care. The registry began collecting data in 2008 and has grown from having just 13 hospitals at its inception to now having 132 hospitals submitting a comprehensive set of data via our Minnesota Stroke Portal, which launched in 2019. Of course, in addition to the registry, we also offer a range of other activities and supports, like these monthly webinars, that are aimed at helping hospitals continuously improve their stroke programs. So when we look at data from the registry, we see significant improvements in stroke quality of care since 2008, and these really boil down to more stroke patients receiving appropriate care more quickly, which we know is absolutely crucial in stroke care. So I won't read through all of these bullets, but they really do show that we've seen an increase in both the amount of treatment being provided and the timeliness of that treatment. So for instance, we see that growth in percentage of patients receiving IV alteplase from 2008 to 2019, and then a decrease in time from arrival to therapy and time from arrival to CT scan. So I want to turn now to sharing some results from this year's hospital inventory survey, which I mentioned played a big part in our performance measures, as well as some of our future planning. The first thing I want to say is a huge thank you to everyone who returned this survey. We had an impressive 94% response rate. So we received 117 completed surveys out of 125 surveyed hospitals. So thank you, that is really incredible. So a couple highlights, particularly from our QI questions. We saw that over 3/4 of our hospitals implemented changes in stroke care practices in 2020. A smaller subset had implemented changes in post-hospital transitions of care practices specifically. And then of those hospitals that implemented changes, 67% saw improvement in a stroke performance measure as a result of QI. And I apologize if you're hearing thunder behind me. The storms that are moving through the city seem to have just hit my area. We also asked you to categorize the types of areas that your QI work focused on in 2020. And you can see in this chart that those leading areas were really improving documentation, working on those key stroke metrics, and then improving stroke code activation processes. So as we move into our next grant cycle, we will continue encouraging and supporting your QI efforts, and Al will speak more to that later in the webinar. So I want to close by talking a little bit about some questions on the survey, which actually focus on our new topic areas for our new grant cycle. Again, these are things that Al will be discussing in more detail, but we actually gave you guys sort of a preview of where we're headed by asking these questions. So most hospitals are already referring stroke patients to clinical services or community resources to support their health and well-being needs. And 41% of remaining hospitals are interested in doing that in the future. Nearly 1/4 of you are using patient navigators or community health workers to follow up with or support stroke patients. And again, 41% of those who are not yet doing so are interested in looking at doing that down the line. We saw a smaller subset of hospitals that are monitoring differences in stroke incidence, stroke care, or stroke outcomes based on a patient's race, ethnicity, or socioeconomic status. And then again, nearly 20% who are interested in potentially working on that in the future. So with that little preview in mind, I'm going to turn things over to Al to talk more about where we are moving next.
Thank you, Mimi. So I'm going to So, as mentioned before, we finished our previous grant in June. Minnesota was fortunate to be one of 13 grant recipients for this new cycle of funding from CDC. In this 3-year grant, CDC decided to make some changes and grow the program in some different ways. While the core components of implementing the stroke registry and supporting quality improvement in the hospital will be continued, the scope of our work will be expanding to address primary prevention of stroke, professional education, and addressing the needs of high-risk patients and survivors, with particular emphasis on eliminating disparities in care and in outcomes. Our body of work is organized by 3 main domains that I've listed here. First, tracking and monitoring clinical measures to improve data infrastructure across stroke systems of care. Second, implementing team-based approaches to enhance quality of care for people at high risk for stroke and stroke patients. And third, linking community resources and clinical services to support people at high risk for stroke and for stroke patients. Within those broad domains, grantees were required to focus on six strategies to implement. I'll read through our strategies first and then talk about the key activities that we're doing to implement these strategies. First, we'll be working to leverage electronic health records and health information technology to identify and support patients at high risk for stroke. Second, we'll be continuing our work on data collection, measurement, tracking, and the use of quality of care data. Third, we're supporting the implementation of team-based approaches to enhance quality of care. Fourth, we are coordinating and developing professional training and education opportunities in both clinical topic areas, but also on subjects that address health disparities and health equity. Fifth, we're partnering with organizations to provide support to survivors and patients at high risk for stroke. And last, we're working with organizations like primary care clinics to utilize and support allied health professionals, such as patient navigators and community health workers, to support the needs of stroke survivors and people at high risk for stroke. There are a lot of activities that our team will be working on, and we'll provide a complete list that you can reference later on. I'll just run through the highlights briefly here so you have an overview of the main activities. First, we're working with a few community primary care clinics, both in the Minneapolis and St. Paul area, as well as in a couple of communities in rural Minnesota, on solutions to identify patients at high risk for stroke. And our goal with these clinic systems is to ensure that patients don't slip through the cracks, that their hypertension and high cholesterol is not only identified, but kept under control, similarly with their diabetes and other medical issues. This is not a new area of work for MDEH overall, but it is a new area of focus for our Coverdell program. And that is, we're venturing out beyond the hospital and into the clinic settings. We'll be partnering with our colleagues internally who have been working with these outpatient clinic systems for many, many years. We're continuing our implementation of the statewide stroke registry. Many of you have been involved in this for a long time, some of you over a decade now. We are working with CDC and the American Heart Association to ensure that the data that you collect on stroke patients continues to be relevant and useful. Over the next several months, we'll be implementing some new changes to the data that are required to be collected. In addition, we are planning to continue our efforts to ensure that the data are of high quality through chart audits. And finally, we'll be working on building new reports that are useful for your performance improvement efforts. In addition, we are continuing our quality and performance improvement efforts. This has been the foundation of our work since the very beginning of our program. We'll be continuing to address performance improvement through acute stroke-ready hospital designation requirements. That is, in order to maintain stroke hospital designation status, hospitals need to be demonstrating that they are implementing QI projects. In addition, we'll be continuing our QI awards program, in which hospitals and soon EMS agencies are recognized for strong quality improvement projects. And finally, we're organizing QI collaboratives, where we convene hospitals to work on a topic together, bringing focus to a specific need or issue to share best practices and help each other overcome barriers and implement projects. We're also dedicating more of our resources towards professional training and education. In this area, we are planning more webinars, short courses on clinical topics, supporting conferences, and developing more resources of all types. In addition to clinical issues, we're going to be bringing attention to the need to eliminate health disparities and address health equity. This is a major problem that doesn't have an easy or short-term solutions. We believe that healthcare organizations and providers play an essential role in this effort, in partnership with public health and many others. One key step that all of us must and can take is to get on the same footing when it comes to understanding the underlying issues that are at the root of these disparities. With this in mind, we're going to be exploring ways to build knowledge, capacity, and experience around what we call the social determinants of health, structural racism, and similar topics that get at the root of these disparities. Our first step in this effort is to get a sense of where you are all at with these issues and what your training and education needs are. By now, the stroke coordinators at all hospitals in Minnesota should have received a survey from us asking for your input about your training needs. Please complete the survey as soon as possible, as we are using this to guide our planning. We just have a few more activities to talk about. Here we are working with the SAGE Plus program at MDH, which supports cardiovascular health screening at clinics for women. These screenings are done for free, in addition to breast and cervical cancer screenings. There are eligibility criteria that must be met in order to participate in this program. And when enrolled, women who are at high risk for stroke and other cardiovascular diseases are supported through a variety of ways. They have access to free resources such as nutrition classes, exercise classes, and other activities to help them reduce their high blood pressure, high cholesterol, and control their diabetes. We're working to expand this program and provide it to women across the state. So if you have more information for questions about this, please contact Kay Hertzfeld. I'll provide her contact information along with the rest of the team at the end of this webinar. In addition, we're working to provide more support to stroke survivors and their caregivers. The Minnesota Stroke Association's Resource Facilitation Program is a free 2-year program in which stroke survivors receive telephone-based support and help getting connected to resources in their local area. We're working with MSA to expand participation. In addition, we're going to be working on providing more information and resources about stroke directly to stroke survivors. We're also working with hospitals to build their capacity and develop more services for stroke survivors. Finally, we're working to help primary care clinics, hospitals, and EMS agencies utilize community health workers, community paramedics, and other providers that we call healthcare extenders. It's our belief that these additional resources can be extremely helpful in connecting with patients and supporting them in their navigating their health needs. We're still developing relationships and figuring out how we can work with various community organizations, community clinics, EMS agencies, and hospitals to support this work. So stay tuned for more updates on this work. In any case, this is a prime example of how CDC and our program has decided to expand our reach from just the acute phase of stroke care out to address the needs of patients both before and after they might have a stroke. I know this is a lot to digest, and there are several new areas that may not be in the scope of work that many of you listening to this webinar might have right now, but we're hopeful that you can appreciate our effort to grow our program and address some issues that are very important. We're excited to be working on prevention, risk factor management, and survivor needs, in addition to the registry, hospital performance improvement, and training. And we're also excited to work on health equity and bringing greater focus to eliminating disparities. With this in mind, feel free to reach out to our team, visit our website, and talk to us about any of these issues and areas. Here is our contact information. And at this time, that closes our webinar, and we'll take questions.
All right, thanks, Al. If anybody has any questions, you go ahead and type those directly into the chat, or you can unmute your line by pressing *6. There aren't any questions in the chat at this time. As you guys can all see in the chat, Mimi has placed the survey evaluation link. So if you could please fill that out for us, that would be super helpful. We use those surveys to help design our future webinars. And if you do have any questions and follow-up, please don't hesitate to email any one of our team members. And thank you for listening and for joining us here today. We'll see you guys next month.